who were authors of this article that reviewed practical use of IDegAsp in a multinational setting. So please take it away, Rupa and Roger. Rupa, I think you need
Great.
to, yeah.
Thank you, SP. So, Roger, we're going to have a little discussion about certain aspects of the use of IDegAsp, and just to clarify doubts and really show this is an effective all-rounder. So, Roger, let me ask you first. We've heard this concept of the main meal. Could you go through this? What about a patient who's used to eating a lot of carbs for 2 or 3 meals? You know, when do we use IDegAsp? What do we need to adjust?
No, thanks, Rupert. I just remember the last time that we did this, we were sitting, I think, in Sydney at a hotel and having a cup of tea at the same time. So hopefully there'll be another opportunity sometime. But, you know, that's a very good question. I think that's probably shown on the next slide just as to how we do it. Jerry and Professor Prasad have also alluded to this. So what we talk about as the main meal is the meal with the largest amount of carbohydrate. And that might be dinner, it might be lunch, but it's the most carbohydrate-rich meal. Jerry's also indicated that that can change. Let's say it's dinner from Monday to Friday, but then on the weekend it might be a little earlier, it might be brunch or lunchtime. So the patient can actually change that Ryzodec dose from dinner, let's say Monday, Tuesday, Wednesday, Thursday, Friday, and move it to lunch on Saturday and Sunday, or brunch. It doesn't matter, because the degludec component of that Ryzodec has such a long half-life that it doesn't really matter when you give it. So you just do that once a day. Now, supposing you have 2 big meals a day, as many of us do, and Jerry said that in Cebu they eat a lot of carbohydrate, but I'm sure that that happens most in virtually everywhere in Asia. Certainly in Australia it does as well, and also in Mexico with wonderful food. So you could then, divide the dose up and then use the Ryzodec twice a day, or IDegAsp twice a day. And again, I think Jerry illustrated beautifully how you could do that and how you calculate, you basically base everything on the basal dose and then ensure that you have enough prandial. So he divided his patients into a split dose in the morning and evening. Now, then if you have a 3rd big meal, well, what I generally do is to add injection of aspartate. So we have patients who have, say, a big breakfast every day and a big dinner every day, and sometimes they have a salad for lunch, and during the week sometimes they have a big meal for lunch during the week. So I have one patient who has, say, a spinach salad with tomatoes and cucumber and a little bit of fish, I think, during the week. So in those days, he would not give himself any aspartate. So he's giving his morning and evening Ryzodec, but nothing at lunchtime. But on the weekend, if he's having a big noodle dish, so a Hokkien noodle dish, or he wants his dessert, then he will have that extra aspartate injection at lunchtime. So Ryzodec, morning and evening, and then aspartate at lunchtime.
Great. Yeah, I think that's really clear.
Yeah, so, but there's so many questions that we could ask, though, and, the guidelines indicate that perhaps use a basal insulin first, but we're really using a lot more Ryzodec or premix insulins as first line, I think, particularly with our diets. But, considering the simplicity of once daily initiation use with IDegAsp, how early would you actually use this in the patient continuum? Because we've got the GLP data, we've got the GLP recommendation first. So when do we start IDegAsp as the first line injectable?
So that's a great question. I mean, in my talk, I talked about this being the first injectable. And I just want to show you this slide, Roger. So this really just goes through the initiation with IDegAsp. And there are several situations where we might consider this. So if you remember Dr. Prasad's case, he was showing us a patient who had high levels of glycated hemoglobin, symptomatic hyperglycemia. So in this patient, we could consider initiating with IDegAsp once a day. Also, obviously, in patients who are having postprandial hyperglycemia as an intensification option, just like you showed in the step-by-step study. And we've put in here preferably low body mass index, just to remember, obviously, we may prefer this because we know in some of the boost trials, there was a lower insulin dose using this co-formulation, so we may get less weight gain. So it might be preferable as well in patients who might be susceptible to increase in weight, but preferably people who don't have an excessive degree of obesity. And how do we initiate? Once a day, and there I've put in some indications. Now, if you've got the glycated hemoglobin above target and also postprandial hyperglycemia. And the rationale is obviously that you're addressing both of these problems simultaneously. You're helping to control the fasting plasma glucose, but also the postprandial glucose. So I think, we can consider this co-formulation not just for intensification, but as we've already said, as the first insulin injectable. So let me just ask you a little bit more about this. So we've talked about, the use of IDegAsp as initiation, but how about when we talk about switching? So switching to IDegAsp from a BD or TID pre-mixed regimen. So can you give us some guidance on that, Roger?
No, thanks. That's certainly very, very important because there are a significant number of people who do need to be switched, where we will consider switching. And as you made very clear in your first lecture, this is a really easy insulin to give because there's no resuspension. It's a co-formulation, so the aspart works as aspart and the degludec works as degludec. They're completely independent, and unfortunately the premixes have been very, very good and are still very good insulins, but they do have that hump because of that interaction between the protaminated insulin and the rapid insulin about 2, 3, 4 hours after giving it. So we do often want to change for ease for many reasons. So let's say someone is on biaspart 30 once a day. That's simple. So we just change them onto IDegAsp or Ryzodec once a day, and it's a unit for unit conversion. That's if the person has suboptimal glycemic control. And this is something we brought out from our paper, where we had a lot of vigorous discussion about how to convert. So most of the time we would actually convert a 1-to-1. Okay, but there are some exceptions to that, and one of those is perhaps when the HbA1c is less than 8 or towards the 7% mark and the patient is experiencing hypoglycemia, then we might in fact decrease the initial IDegAsp dose by around 10 to 20%, okay? Because we know that that degludec component is actually going to work a lot better than the protaminated aspart, and often you need less insulin, as you've shown or discussed in the boost studies. So 1-to-1. So with biaspart 30 twice a day, also change a 1-to-1 to IDegAsp twice a day. Again, unless that HbA1c perhaps is getting towards 7%, so below 8%, or if the patient is experiencing hypoglycemia, then again reduce the dose by about 10 to 20%. So 1-to-1 unless that HbA1c is lower. But there are some people on 3 times a day premix, so biaspart 30, 3 times a day. So what we would do there is not use Ryzodec or IDegAsp 3 times a day, but we'll split the dose over the main meal, so twice a day. Okay, so calculate the basal component again, as Jerry showed, and then split that over the main meals, say breakfast and dinner, and then you probably need an additional aspart dose to cover the 3rd meal. So those are guidelines, and again, with clinical experience, I think we've learned to reduce the dose if the HbA1c is a little lower, because we now know that often the Ryzodec group will need less insulin as compared to the biaspart 30 group, again because of that degludec component. Okay, so we've talked about initiation, we've talked about switching from other insulins, and again, both, Dr. Prasad had some lovely cases on initiation, and Jerry had some very nice cases on how to switch. But again, it comes down to the patient, and my terrible situation where the patient hadn't been giving any insulin or giving insulin at the end of the meal rather than the beginning of the meal. So what are your practical tips on patient education during this process of intensification or switching, Rupa?
So that's a really important question. And I think it's something that we face on a daily basis in our clinical practices. So I think this slide really does summarize what we do need to do. So we have to make sure our patient has the right information about Ryzodeg and the pen and the injection. Okay, I think that's essential, how they should store the insulin, how they need to use it, where they should inject. I mean, often with the first injection, I show them in the consulting room, and if I don't have a dummy pen, they may actually want to inject with me there and then. Again, with diabetes nurses, educators, nutrition therapists, these are very useful aids for educating our patients during insulin switching. Sometimes these aren't available, and we do need to take over those roles. We can't assume that our patient will automatically understand everything we say. Remember as well that it's really important to emphasize a disciplined meal schedule. This will be very difficult to achieve this switching or intensification if the patient skips meals or is varying their meal times a lot. So we need to make sure they're on a regular diet. You may need to educate on carbohydrate counting, and more than anything, I think it's a close follow-up. So when I'm going through this with the patient, I often tell them, call me, send me a message if there are any doubts or difficulties. And on the right, I've shown you the dose adjustment algorithm, and it's a +2, -2, which is very simple to communicate to our patients. So really, it's just follow up, giving the support that the patients need so they have the confidence to do this by themselves and also to continue titrating. You don't want them just to stay on the same dose that you started them on in the office. So that's really important, and having the confidence to do that will need support from us. So that's a great question, Roger.
And you talked about titration. How often would you recommend that doctors help or nurses or doctors help the patients titrate the insulin?
Well, it can either be once a week, but I generally do titrate up to twice a week. So sometimes if I have a patient who's quite uncontrolled, I may want to go a bit faster. So 2 times a week may be the titration algorithm that I use.
Yeah. That actually reminds me of that, because you got to ring someone after this meeting finishes to titrate up his Ryzodeg. Actually forgot to do it earlier, but good reminder. Okay, we've talked about the clinical studies and the molecule and, the Ryzodeg co-formulation and the chromatography. We've talked about a lot of studies, but in the real world, what are your reflections on what we have? And could you tell us what's actually been happening out there in the world as far as gathering evidence in, clinics in, Africa or India or Southeast Asia?
So, the importance of real-world data has become really relevant. Real-world data really helps us support what we find in the clinical trials. So, in the clinical trials, the patients tend to be very selected. And we do need to verify really the performance of any new drug or insulin in the real world, just to see if it really follows what we're finding in the phase 3 clinical trial programs. So now a lot of data has been collected regarding IDegAsp. We've had survey data, we've had retrospective studies, we've had database studies, which are often, huge numbers of patients, observational studies, and obviously pragmatic trials. So let me just show you some of the papers that have been published. So you can see there's a lot, retrospective studies and observational studies. Now, I can't go through all of these, and each of them have their own specific design and their own specific objectives. So I'll just concentrate on a couple. So on the left-hand side, I'm showing you the results of Dr. Kalra's work. This was a retrospective observational study of Indian patients switching to IDegAsp. And again, the results I'm showing you here are after 6 months and 12 months. And you can see there's a significant reduction in the glycated hemoglobin, about 2%. And there's also a significant reduction in the daily insulin dose, about 5 units at least. The second study is looking at patients who were previously treated with pre-mixed insulins. And I'm just showing you the blood glucose profile here. So this was switching to IDegAsp, and you can see this improved the daily glucose level variability. And also patients reported benefits in their quality of life questionnaire as well compared to the pre-mixed insulin. So these are just two studies really just showing what kind of data has been published. But we also have other real-world activities for IDegAsp. We have studies in India, in Japan, in Korea, and for example, the PASS study, and also the ARISE study, which I'll just show you the actual study design. So this is a real-world study, and the results will be available very soon in a population of about 310 insulin-naive patients. So these are patients who are treated with any anti-hyperglycemic medication other than IDegAsp for at least 26 weeks before entering the study. And then they were switched over to IDegAsp and observed until the end of the study. So the objective here is to investigate the effectiveness of IDegAsp on glycemic control in a real-world population who have been initiated or switched to IDegAsp from their previous treatment according to local clinical practice. So this, I think, will give us a lot of data. You can see it's a multinational study. In fact, Australia is included here, India as well, Malaysia, and this study will give us very useful information as to how effective IDegAsp is in this kind of real world setting. So yes, we have a lot of data, most of which has confirmed what we're seeing in the clinical trials, but this still data will keep coming in. And again, I think this is really useful for any clinician.
No, thanks, Rupa. I think it will certainly be very interesting to, in a subsequent meeting, hear from the investigators and, of course, hear about the results of the ARISE study. We have, I think, tonight definitely delegates from Malaysia, from India, Philippines, and I don't think anyone's from South Africa. We may have some from Saudi. I'm not sure. Okay.
So let me go on from that, Roger. So we've talked about clinical trials, we've talked about initiation, switching, we've talked about real-world studies, but I just want to go into IDegAsp having been kind of tested in, for example, Ramadan, and also for other religious fasting. Do we have data on that, and what do the results show?
Sure. And of course, that's a very, very relevant question at the moment because Ramadan is about to start, I think. And certainly we, again, countries such as Malaysia, Indonesia tonight, the Philippines and elsewhere will have Bangladesh, etc. Will have patients where this becomes a very relevant issue. This is always a fascinating topic, and Mohammed Hassanin from the UAE taught me a lot about managing patients in Ramadan with diabetes. And if the delegates wish to have a better look at this topic, there's a lot of information on the IDF or the diabetes and the so-called Diabetes and Ramadan website. Let's look up Mohammed Hassanin. So this was a very interesting study. First of all, during Ramadan, unfortunately, we know that often glycemic control actually deteriorates for a number of reasons. There's fasting during the day, but often a lot of feasting during after dark. This was an interesting study called the IDegAsp Ramadan study, where we had nearly 260 patients, and they were randomized, all with type 2 diabetes, randomized either to receiving IDegAsp twice a day or Biaspart 30 twice a day, and they continued their oral anti-hyperglycemic agents. Now, the important thing here is that prior to Ramadan, for a period of up to 20 weeks, there was a so-called treatment initiation period. So patients had their insulin doses titrated during that time. So initiated on either insulin or continued on insulin, but either randomized to Ryzodeg or Biaspart 30, and they had them titrated. The titration occurred very, very rigorously for up to 20 weeks. Now, once Ramadan occurred, the insulin doses were reduced by 30 to 50% at the suhoor dose, so that's the morning dose, and the oral anti-hyperglycemic agents were continued for that 4-week period. So you have a initiation period where a lot of the work's done, and then you have this dose reduction in the suhoor dose at the start of Ramadan for a period of 4 weeks. And then the patients are then followed up for another 4 weeks post-Ramadan, and there's a 30-day follow-up period. So a very, very comprehensive study. So at the end of the 4-week Ramadan period, the doses were readjusted to the initial, the initial doses during that run-in phase. So there were two choices I mentioned, and most commonly this occurred. Choice one, sorry, in my screen, the writing appears to be getting sort of blurring in and blurring out, so it's creating a bit of a interesting dilemma. I hope it's actually not my eyes, but anyway, choice one was where the latest breakfast or lunch dose was reduced by 30 or 50% and taken at the dawn or suhoor meal. The sunset meal or iftar dose should be left unchanged. Okay, so the iftar dose generally is left unchanged because the meal is the larger one at that time, while often the suhoor dose is often lower because the meal is quite little or contained. Choice two is where the latest insulin evening meal dose should be reduced by up to 50% and then taken at the dawn or suhoor meal, and the latest breakfast or lunch dose should be taken with the evening meal or iftar dose. So there are a couple of choices. So let's have a look at the results, the next slide. So at week 26, in fact, what they found was that there was no difference in HbA1c, and there was a similar dose in insulin in both groups. But what was found, and again, a consistent finding when you are looking at IDegAsp and comparing with other insulins, is that the rates of hypoglycemia are low, and particularly nocturnal confirmed hypoglycemia, reduced by 83%, which is a very, very large decrease. Confirmed hypoglycemia was also significantly lower by 74%. So it means that, for those who choose to fast, who are on insulin during Ramadan, this in fact provides a very, very feasible and safe regimen to use if you need insulin. So IDegAsp twice a day.
Yeah, and obviously you've talked about Ramadan, but those aren't the only religious feasting and fasting aspects. So, this is a great example, but in general, is there any advice for people who want to fast?
Yes, so if they fast, again, you have to give if you give IDegAsp, you're going to have a meal. Okay, so Ramadan, I guess, is the most consistent sort of type of fasting where you have this very well defined 4-week period, and you train people 4 to 6 weeks beforehand. What is more complicated, I guess, are those who decide to fast on one day of the week or twice a week, or they change their diet for that week, and again, or they change the meal timing. So we know that, for example, that first of all, there can be that flexibility in when you actually give the Ryzodec from day to day. So that helps. So if you don't want to have dinner, then you have it at lunch. Say you don't want to eat after dark, then you give it at lunch, or you give it at breakfast. So there can be that flexibility. If, however, if you have someone who is, say, on insulin and leading a very, very erratic type of, diet, so carbs vary considerably, sometimes fasting, non-fasting, sometimes, then probably this insulin is probably not going to be the best. So you probably need a basal with a bit of top up.
Great. Yeah, that's great. That was really good, Roger.
Okay, so Rupert, I guess we talked about fasting, and look, there are other situations where there might be fasting as well. So my answer probably doesn't answer everybody's situation. That's where, again, the beautiful relationship between the clinician and the patient is so important. That's vital. But we focus on clinical trials and real world evidence, but we have a whole range of people who may be on insulin, and increasingly we're getting older and older people, and unfortunately elderly used to be more than 65, which is, now I think about it, completely ridiculous term. But let's say a patient is 75, 85 or 90. What about the experience about using IDegAsp in that group?
Yeah, like you say, it's always important to look at the data in special groups. As you say, in the clinical trials, they often don't include elderly patients. So really for an elderly patient, remember, if frailty or multiple comorbidities are there, we do need to have less stringent glycated hemoglobin targets. There's no point putting a target of 6.5 in someone like this. We're going to cause more harm than benefit. Remember here, IDegAsp is useful. Remember, it's a single injection. It's just one pen. These patients won't have to deal with two pens and maybe confuse their pens, and a reduced number of injections that we've seen with IDegAsp in place of perhaps a basal bolus regimen. Remember as well that many elderly patients are in care homes. So here they may need nurse assistance, and if the arrival times of nurses tend to be different to what you would want, there is the possibility of flexible dosing with IDegAsp. And finally, as well, meal times may vary as well in these patients. And again, flexible dosing may be an advantage. So this co-formulation can be of particular use in this group of patients. But let me go on to another group of patients, Roger. So what about patients, adolescents and children with type 1 diabetes, and also adults with type 1? What's the experience with IDegAsp in this group of patients?
No, thanks, Rupert. If I could start off, I guess, with adults with type 1 diabetes. Look, again, we usually try for a basal bolus regimen, or we may use pumps. So there's a variety of different types of insulin that we could use. But there is good clinical trial data in those who don't want to inject multiple daily injections. And again, there's one I saw earlier today who was supposed to be on basal bolus, but was consistently not giving any insulin, basal insulin at night. So we've got him on some IDegAsp at dinner time, and he gives mealtime aspart doses at breakfast and lunch. Look, I don't pretend with him that it's ideal at the moment. We have a lot of work to do. He wasn't monitoring his glucose levels, and he hadn't seen me for 1 year. So today was the first time. So we've increased his Ryzodec, and I've now got him on the Libre, the Freestyle Libre. So we'll have a bit more data hopefully in the next week. But it certainly provides an alternative. There is a nice study which was published comparing Ryzodec use once a day plus mealtime aspart once or twice a day. The comparator group were those, again, everyone with type 1 diabetes, and they had detamere or levemir used twice a day plus mealtime aspart. So what they found, again, was that there was very, very identical HbA1c, similar fasting plasma glucose, but interestingly, again, less overall hypoglycemia and less nocturnal hypoglycemia in the Ryzodec group. So it's an alternative. It's an alternative for those who won't inject basal bolus. And similarly, in the children's group, there's also a pediatric study which shows similar findings. And again, one would say that, look, it's a pragmatic treatment option in children or adolescents who omit doses. In our very limited experience of type 1, at least the patients don't end up with diabetic ketoacidosis. Control hasn't improves a little bit so far, but they haven't come back yet, on a regular basis. They've got to see us still, which emphasizes the need for us to see our patients and evaluate, not just put them on an insulin and then leave them alone. In the children under the age of 2, there's no clinical experience. 2 to 5 years, there's a special caution due to the higher risk of severe hypoglycemia, but there were reasons for that. I think in most countries, Ryzodec is approved for people down to the age of 2. But again, it's type 2 diabetes mainly, but it can be used in type 1. But I think only in a very skilled and contained setting and for good reasons.
Great. Yeah, that's really useful information.
Yeah, so now, Rupa, you mentioned, I was very glad, just moving back to the elderly people, I'm very glad that you mentioned that we're not looking for HbA1c levels of 6.5 or 7 point, we're getting people who are older and older, 85, 90. I've got a 95-year-old now. There's one of my patients who I'm going to transfer over to Jerry when he goes back to the Philippines. He's probably in his late 70s, and he is adamant that his HbA1c should be around 6.5%. And he's been hypoing, and he says he's going to, write to the medical board if he develops developed retinopathy because of me. But then he, probably has a hypoglycemic episode a couple of times a week. But he said he'll listen to his doctor in the Philippines. So I now have an ideal person I'm going to refer to. Thank you, Jerry, very much. But just in the last question in this part of the discussion, or the last couple of questions, we've talked about the various age groups. We know that we can't use this drug in pregnancy because there's no safety data as yet. But what about in patients with comorbidities such as renal impairment or with hepatic disease? What do we have to be mindful of, if anything?
So, I think this slide really does summarize the main things that we should consider. So remember the PK/PD profiles of the individual components of IDegAsp are unaffected by both renal impairment and also hepatic impairment. But remember, again, you need to ask for intensive glucose monitoring and individualize the insulin dose in these patients. Again, I tend to go quite slowly in titrating. I'm well aware of the hyper risk in renal impairment. And remember as well, in dialysis, we need to be as well extra cautious. So we can use this co-formulation in both of these situations. But again, you need to select your patient. You need to ask them to monitor. And I would probably go slow in the titration. So I think that would be the only practical advice there. So I think with that, I think we can hand it back to SP. And Roger, I love the way you're referring patients between us. I'm just waiting for your first Mexican patient to arrive so you can send them over to me.
I do have one. She developed type 1 diabetes while in Australia, so she's moving back very soon, Rupa.
Thank you. Thank you.
Right. Thank you very much, everyone. Thanks for taking us through a very comprehensive session of talks that talks about initiating combination co-formulation insulin and then how to intensify. And this conversation that you had between Roger and Rupa has been very informative. There have been lots of questions that have come through, and I'm going to try and answer all of them. All right. I will try and be systematic. I will be happy if you jump in. All right. The first is, how do you decide when to initiate a basal insulin versus the IDegAsp option? I do know that it was covered by Rupa, but obviously the person who is listening needs to have this re-emphasized. Perhaps I'll start with Rupa, and perhaps then Jerry can chip in.
So, there are a couple of situations. Now, I talked about extreme hyperglycemia, especially symptomatic hyperglycemia. If you remember, Dr. Prasad presented a case in which we used IDegAsp to cover glucotoxicity, but generally you're going to use it in a patient where you're seeing that there is postprandial hyperglycemia as well as probably fasting hyperglycemia, because this co-formulation will cover both aspects adequately. So we're more likely to reach target using this rather than just basal insulin. I don't know if anyone else wants to jump in with any more information.
Maybe Jerry, talk about the type of patients you see in Philippines.
Actually, the issue of whether to use basal versus IDegAsp or the co-formulation, almost always I'm happier if I start patients as an initial agent using the co-formulation rather than the basal, because almost always, as you've seen, based on the Filipino meal, we don't only eat lots of rice during each meal, but we also have lots of carbs during each snack. So we really have a problem with postprandial hyperglycemia. So I find it easier and I find it more successful in terms of lowering A1C by using the co-formulation rather than starting the patient on basal.
Yeah. There's a question, quite many of them, talking about what is the appropriate timing of taking this IDegAsp. And the first question that came was addressed to Professor Prasad. His patient that he started the patient on IDegAsp at lunchtime. The question was, why lunch? And, can you change the timing? And then there was a question about, can you change it one day breakfast, next day dinner? What do you tell your patient, Professor Prasad?
Yeah, thank you very much. Actually, the large meal idea, the large meal pattern, we select and prescribe the IDegAsp at that point of time. That we just ask the patient, what is your feeding pattern? And if the patient tell us that, oh, I take most of my carbohydrate at lunch, then the IDegAsp initiation should be at the lunchtime. And if the patient tells us, okay, sometimes I take meal with large carbohydrate at dinner in some point of the week, then like weekend or something like that, we can switch over to the dinner time. So one day can be managed actually, and we can switch over to the different time period. So it depends on the patient's feeding pattern. So convenient is cover both basal and bolus with a single shot, and the large meal idea should be there, and you will have to take a very good history, and you can prescribe in that way. Thank you very much.
So you say that sometimes you can take it at breakfast, sometimes you can take it at dinner. Is that right, Professor Prasad?
Yes, you are quite right. Yeah.
How flexible do you actually have patients who fix their Rhizodec dose at different times? Roger, do you have patients jumping all over the place when they take the IDegAsp?
Yeah, thanks, SP. I think the main way they jump over the place is, again, what I mentioned during the talk is that usually the largest carbohydrate meal might be, have I frozen? It's interesting watching yourself, isn't it? But basically, it's the largest carbohydrate meal usually, and that might be, during the working week, it might be dinner, and that's the most likely scenario for us in Australia. It might be overseas as well. But sometimes during the weekend, what they do is that they decide they have a very large meal at, say, 10, 11 o'clock in the morning. So there's no reason why they can't actually give the Rhizodec at that time of day on those particular days, and then they have a lighter meal at night. If they want to have two large meals on the weekend but only have one large meal during the weekday, then they could top it up with a bit of aspartate. So that does provide a lot of flexibility.
Rupa, there is a question about how close can the two injections of IDegAsp be? That's quite a number of times question.
So that has to do, obviously, with the properties of degludec. So degludec gives us this advantage that we can have, for example, if you have a BD IDegAsp regimen, you can have the two injections, for example, in the morning and in the lunch. That maybe with a traditional BIASP 30 regimen might be more difficult because of the characteristics of the basal insulin there. So with degludec, as long as there is at least a 4-hour difference between these two meals, we can give the two injections in two subsequent meals. And the reason with BIASP 30 we can't really do that is because you're likely to get overlapping of the basal insulin effect and therefore a much higher risk for hypoglycemia. With IDegAsp, we don't face that problem.
There's a question on if you're on once a day IDegAsp, right? Does the IDegAsp once daily cover all 3 meals? Perhaps Professor Prasad, you might want to try and answer that. I think it's frozen. Jerry. Jerry. Oh, okay.
Hello.
Yep, gotcha.
Yeah, I mean, so the thing is that it depends upon the meal pattern. Like Philippines and in our country has rice-based meal. If the patient managed to take less carbohydrate, possible to cover all the one Rhizodec, and certainly there will be metformin. And but I think that if you get a good baseline blood sugar with basal insulin like degludec, if the fasting is very good, then the postprandial management is quite well in initial period of the diabetes population, right? 2 years, 5 years, 7 years diabetes you can manage. But if the duration of the diabetes is quite long, more than 10 years like that, you cannot manage it once daily. That is a point. So the duration of diabetes is a point, and the pattern of carbohydrate intake in this patient is very important. So by considering these two things, you can manage the all three meal with one single shot of Ryzodeg.
Jerry, you and I have patients who eat carbs all the time, right? So can you, there's this question, could you try and answer this question? One jab of IDegAsp will cover all 3 meals.
Actually, SP, I'm very particular. Tell my patients that if we are going to be successful with your control of glucose, we have to be partners in the therapy. So I always tell them, I'll give you the pharmacotherapy. I advise you about medical nutrition therapy. These two should go hand in hand. And this is where they have to understand that if you want once a day injection, we probably can do it. I can add an oral agent like a DPP-4 inhibitor that will target the prandial blood glucose, whereas I'll give the IDegAsp once a day on your biggest meal. We can be successful. So these are some patients where in once a day will probably work, but this should be compliant patients.
Very good. Right. Rupa, the question is, once daily IDegAsp, can you add sulfonylurea on this regimen? Good question.
So, it's a good question. I think, yes, of course you could. But honestly, with insulin, the recommendation is that we actually don't choose another agent that will increase the risk of hypoglycemia and also weight gain. So that would not be my first choice as an oral agent to add in to an insulin regimen, whether it's IDegAsp or basal bolus or any insulin regimen. I probably wouldn't choose to add in a sulfonylurea. We have a lot of other options now. You could add in another injectable, a GLP-1 receptor agonist. You could add in other oral agents, just like Jerry mentioned, a DPP-4 inhibitor or an SGLT2 inhibitor. Sulfonylureas do have their place in diabetes management. I don't want to knock them completely, but on top of insulin, I think we would increase the risk of hypoglycemia and weight gain.
You mentioned GLP-1 combination. There was a question. Can you combine the two?
So there are fixed ratio combinations of basal insulin with a GLP-1 receptor agonist. There are 2 formulations available right now, degludec combined with liraglutide, and obviously glargine combined with lixisenatide. So they have obvious advantages. You've got one pen, you're tackling as well, fasting and prandial glucose, low risk of hypoglycemia and weight gain. You could also do this separately. So you could, as the algorithm suggests in the ADA and also even in the Malaysian guidelines, you could start off with a GLP-1 receptor agonist and add in basal insulin as well. So there is no recipe that covers all possible options, but I'm just telling you that these are the possible ways we could use a GLP-1 with insulin. You could add in a GLP-1 receptor agonist on top of IDegAsp as well, or vice versa. So we have a lot of options. It depends on the individual patient characteristics and what our patients want. You need to have that conversation with them.
If I might just jump in, I quite agree with that. We've now got a very large number of patients who've been on Ryzodeg who do well, but perhaps they would like the insulin dose lowered or would like to lose a little bit of weight. So we're using a very large amount. We have the ability, I guess, to use, in the past we've used twice daily exenatide, but now we have once weekly semaglutide and other once weekly agents, and they really do very well with that combination.
Roger, since you're on the line, there's a question on what is the difference between Novomix and IDegAsp?
Okay. Novomix is the brand name. No, I've got it wrong. Sorry. Novomix is biaspark 30. So it contains Novorapid and protaminated Novorapid, or aspart and protaminated aspart. So it's Novamix 3070 or bi-aspart 30. Okay, so that's the modern premix. Before that, we had the human premixes, which are Mixtard 3070 and Humulin 3070. Now we've come another 10, 15 years, and we've got this co-formulation of aspart and degludec. So that's IDegAsp. I'm getting it right, I think. So this is the co-formulation, which is different from the premix, which is Novamix or bi-aspart 30, which is where you have the interaction, as Rupert said, between the aspart and the long-acting aspart or protaminated aspart, and there's that 3 to 4 hour hump of increased hypoglycemia risk. While with IDegAsp or Ryzodec, there is 2 insulins which completely independent and no hump. I did that very badly, I think.
I think you're half asleep, Roger. Okay, so the question is, Jerry, how would you switch a person who's on Novamix to IDegAsp?
Okay. That's also very common. Most of the patients that I mixed from premix like Novamix to IDegAsp is when they have actually, even if they're in good control, but they are high, they have several episodes of hypoglycemia. So when I switch them to IDegAsp, I switch them into 1:1 ratio. So whatever is the dose, if their A1C, let's say, is above 8%, it's 1:1. If it's close to normal, I probably reduce the IDegAsp by around 10 to 20%.
Okay. There is a question on if the patient is on IDegAsp twice a day, which dose do you titrate first? That's a really brilliant question. Perhaps Rupa, would you like to start?
I mean, really, I think it depends on which your biggest meal is. So if it's your breakfast, you'd probably use the before dinner glucose levels to help you titrate your breakfast dose. If it's dinner, for example, it would be your fasting plasma glucose, which you would use to titrate that dinner dose. So I think it just depends on when is the biggest meal. Start with that dose probably, but you could do them both simultaneously as well if you go for a 50-50 split of your IDegAsp.
Is there any, worry? If you do one and then do the next, how many days apart would you do it?
Well, probably you'd need to follow the PK/PD characteristics of IDegAsp. So you'd probably wait 3 days to see the effect of your first titration, and then see how much you need to work on the second dose, if that makes sense.
Absolutely. Right. There is a question on a patient who are on basal bolus insulin. How might you convert them into the IDegAsp regimen? Any one of you want to jump in?
Well, I think Jerry did it very brilliantly. Okay, so you could look at the total basal dose of that they're on. So let's say on glargine 40, 50. So that then becomes the total basal component of the Ryzodec. So whether it's used once a day, and then you can add on and calculate the prandial component. So again, let's say 50 units of glargine, and you want to switch them to Ryzodec twice a day. So you want about 25 units twice a day of the basal component of Ryzodec. So that's going to be 70% of the total dose twice a day.
Barry, is that correct? Is that how you would do it?
Yeah, I actually illustrated it in my case. I basically, it depends again on the A1C level of the patient. If, like my case, wherein the A1C was around 8.5%, so I can safely switch the patient to IDegAsp, but I based it on the dose of the basal insulin. And then 1:1 ratio, then I split it into 2 during the 2 minutes. Yeah.
So just to let you know, thank you so much. We should be winding down very soon. Professor, maybe I should ask Professor Prasad, do you have any problems when you have patients, like I do have too, who are on complex insulin regimens and have problems monitoring themselves?
Oh, yes. As we see in the studies that, and practically we see in our clinics, that when you prescribe basal bolus regimen, and at least 30 to 40% patients actually miss 1 or 2 doses of this insulin. And when you give this basal bolus insulin, so 4 shots a day, and you need to monitor very frequently, like 3 or 4 times daily, ideally. So patients are exhausted, and within a month or more, patient actually they drop out in their follow-up, and they're exhausted. So that is a problem, and patient frequently comes back from home, and they tell that, okay, doctor, can you switch over to a simpler regimen? So if you can control and achieve the same HbA1c with only 2 shots instead of this 4 shots, why don't we can switch over to this twice daily insulin like IDegAsp. You can see the studies that chances of hypoglycemia is less, and the HbA1c is almost similar to the gold standard HbA1c control in with this basal bolus regimen. So it would be very convenient for the patients to switch over from this basal bolus to this twice daily. Sometimes patients tell us, "Oh, doctor, this is inhuman. You're just injecting me 4 times a day and asking me to monitor so many times." So we have to switch over to twice daily many a times.
Thank you very much. Yes, Rupa.
So talking about the monitoring, I think with the Freestyle Libre system, that's helped our patients so much. But for me, it's not so much so I can see their glucose profile. I want them to see their glucose profile. And they realize that after a particular meal, the glucose jumps up, and that really does help them make changes. So I find it as a great educational tool as well for our patients with the lifestyle changes that Jerry mentioned.
Another thing is that we don't have this Freestyle Libre in our country, so we'll have to be on traditional things on finger pricks. Yeah. That's the problem.
It's still very, very expensive in many parts of the world, and including Australia. So we might use it once every 3 months or 6 months, 2-week period.
Yeah, I ask for it just before the next appointment if they can afford to have it. So.
Okay, all good things have to come to an end. Thank you very much. We are close to finishing time. Just one final statement from each of you to the audience who have been very loyal at listening to us. Perhaps I'll start with Rupa, then Prasad, and Roger, and then Gary.
So I think during this session, we've covered all the aspects of this co-formulation of insulin degludec with Aspart. So my only message would be, you've seen that you can use it in so many scenarios. It has the advantages of efficacy, often reducing insulin dose, and obviously reducing hypoglycemia risk. For me, it's a very, useful tool in especially my type 2 patients as an initial insulin, but also as an intensification option. So I would just say, please try it.
Professor Prasad.
Yes. The thing is that the days are advancing, the science is advancing from this animal insulin. The development is continuous, and these are for the sake of the the life of this patient. So we must have to cope with the advancement and try these things for betterment of our patients, less hypoglycemia, less weight gain, and better life for our patients. So should try it.
Thank you very much. Roger?
Yeah, what I was going to say is what I think one of the other speakers alluded to, which is quality of life. And one thing that Ryzodec, well, many things, but one of the key messages I've got from patients is that it's much more consistent in its effect from day to day as compared to many other insulin regimens. So they don't have to suspend their insulin. The 2 insulins work independently, and that degludec component is just so predictable from day to day. So less variability, more confidence, and it really does potentially have a very significant positive effect on their lives.
Jerry.
Yes, first of all, Novo Nordisk will always be one of those pioneering pharmaceutical industry that are partners with physicians, not only in helping support CME, but also in trying to develop new technologies and new medications. In fact, in the 100 years of insulin, Novo has always been partners with us, patients and physicians. And now with the IDegAsp, it is a revolutionary insulin that has really revolutionized the way we treat patients with diabetes requiring insulin. Thank you.
Thank you very much. Before we close the session, I'd like to introduce Dr. Vinay Prosti, who